Good morning, good evening, good afternoon, everybody. It is 7 p.m. in Paris, 12 p.m. in Nashville, 1 p.m. in Boston, and it is my a great pleasure to welcome you all to this new journal club brought to you by the International Academy for Clinical Hematology, the ICH. My name is Mohamed Moti and from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is my great pleasure to moderate this journal club dedicated to this paper just recently published in Blood. So I think we all agree that neurotoxicities after CAR T cells are probably one of the most challenging complications in the field. And although CAR T cells are bringing hope and probably cure to many patients, we still need to be aware and learn how to manage some of these long-lasting, maybe refractory toxicities like the MNTs and the non-ICANS toxicities. And this is a very timely webinar because the ASCO 2025 Congress has just finished, and we've seen the presentation and simultaneous publication in JCO of the paper about the long-term follow-up of cilta-cel in relapse refractory multiple myeloma, namely the CARTITUDE-1 trial. And indeed, one of the complications that patients are facing over the long term is about some of these non-ICANS neurotoxicities. So I thought the choice of the steering committee was very timely getting this paper. And we're very lucky to have two great experts today to discuss it, namely the senior author, Dr. Matthew Frigo, from Boston. Thank you, Matthew, and congratulations for a great paper. And we have also Dr. Baggy Dolaria from Vanderbilt in Nashville, who will be the expert panelist discussing with Matthew. And usually I spend much more time summarizing a paper. However, I thought this paper is very straightforward. The summary is that cyclophosphamide is probably an effective treatment strategy to mitigate steroid refractory courses of non-ICANS. And I thought, I'm going to stop here and without going into the details, because obviously Matthew will provide us with some details, and go immediately to the discussion. And of course, you are more than welcome to share your questions and your comments, and I'll do my best to distribute them among the two panelists. So Baggy, Matthew, thank you for joining us. Good afternoon for both of you. And I'll start as usual with the non-co-author, Dr. Dolaria. So Baggy, can you just give us a brief overview introduction about the issue of neurotoxicities after CAR T cells, and why is this important? What are the symptoms? What are the current treatment algorithm, and what are the challenges we're facing? And then I'll switch to Matthew, who will give us more details about his work.
Thank you, Professor Moti, for kind introduction and the invitation to be part of this journal club from ICH. So the CAR T related neurotoxicity has been known for over almost a decade now, initially with CD19 CAR T cell therapy, where patients typically presented with aphasia, confusion, word finding difficulty, and dexamethasone actually systemic steroid works very well in majority of those traditional CD19 CAR T associated neurotoxicity. Subsequently, as BCMA targeted CAR T cell therapy in relapsed refractory multiple myeloma become available, we recognize this as a separate entity, which is happening late in the course after the CAR T cell infusion, where almost like you can think about it like a second wave of neurological side effects from this BCMA CAR T cell therapy, which has not been described with other type of CAR T cell therapy in leukemia and lymphoma, which tends to happen roughly 3 to 4 weeks after the cell infusion, where patient has nearly recovered from all the CRS and typical ICANS side effects. And these patients present with a whole host of neurological symptoms, starting with just some personality changes, mood disorder, balance issue, and tremors. Occasionally isolated cranial nerve palsy has been described. And right now we have 2 different BCMA targeted CAR T product, namely the ide-cel and cilta-cel. And this has been described with higher frequency with the cilta-cel compared to ide-cel, but though there have been reports of this happening after ide-cel infusion also. And given the rarity of this event, it's not as common as traditional ICANS, the standard management, what to do for this patient is really still being explored. And different groups have tried different approaches, and the most easiest thing to do is to just put them back on a little bit of systemic steroids to suppress the CAR T activity and see if it helps. And at least in my limited personal experience, it doesn't seems to be that effective as it is with the traditional ICANS, and patients continues to struggle with the balance issue, mood disorders, and many times kind of almost become a bedbound because of inability to walk independently. So that has led to clinicians and investigators to try second-line immunosuppressive drugs, ranging from anakinra to intrathecal chemotherapy to, as we are going to discuss in this paper, systemic cytotoxic chemotherapy like cyclophosphamide. So I think this paper is very timely because rapidly expanding use of cilta-cel in earlier lines of therapy, and we are using it in increasing frequency with myeloma patient with older age, with prior neurological comorbidities and organ dysfunction. So I only anticipate that this problem will become more frequent as we move and expand the use of cilta-cel. So this adds to the literature of how to manage this toxicity.
Thank you very much, Baggy. And we'll come back, I think, because we already have questions about the issue, the differences between products and targets. But Matthew, what was the rationale behind using cyclophosphamide in your case for these patients with refractory non-ICANS neurotoxicities?
Yeah, no, it's a really good question. And the honest truth is, we actually don't really know what causes this, right? So we don't know what the mechanism that's driving a lot of this non-ICANS neurotoxicities. I think we have a fundamental understanding of ICANS itself and kind of how it relates to CRS, macrophage activation, ICAT, and all the kind of like inflammatory components that we think go into this, which is why we think things like anakinra, emapalumab, and steroids tend to be effective, right? And what we typically see in this kind of second wave of toxicities about a month out is this development of this movement disorders, personality changes, and some of it can be very subtle. Some family members may say that mom or dad are just less interactive at family get-togethers. And so I think some of this may be underdiagnosed, especially when, it can happen over 3 to 6 months, where patients may develop a gait abnormality. And if they're older, sometimes their primary doctors don't link the two together. But, we had our first case of this occurring, and the patient actually progressed pretty rapidly with Parkinsonism and went to hospice. And this was despite high-dose steroids and anakinra, the typical kind of anti-inflammatory approach. And back on the early CARTITUDE studies, they did actually try Cytoxan for some of these rare events. And I'm not talking the cranial nerve palsies, I'm talking more of like the pure Parkinsonian-like features. But they did it about 500 mg per meter squared, and to a much lower dose. And so they were kind of giving a single dose, and they weren't necessarily seeing ablation of the ALC at least, or CAR. And more data were coming out at that point in time that the ALC is strongly correlated with the onset of these symptoms. And so what we elected to do at that point, given we had another patient who was developing these symptoms and progressing, is that we felt that maybe just higher doses of Cytoxan for a deeper ablation of the CAR T cells may be warranted. Again, we don't know the mechanism. Therefore, just like with steroids, we were using a pretty broad gun. And so we did 2 grams per meter squared. And what we saw is that in the first publication that we actually published, we saw that the ALC dropped pretty precipitously, although we never really stopped detecting CAR T cells in the peripheral blood. And then if you follow that same patient who's still in a complete response from their myeloma over 2 years out, I believe, and still has not recurred from their symptoms, and he was bedbound and completely basically non-interactive when we were treating him. He still had CAR T cells at 90 days following his infusion, despite resolution of symptoms. And when we isolated those CAR T cells, they were still functional in vitro. And so it's this interesting situation where we have expansion of cells seeming to correlate with toxicity. We see that ablation of the cells during peak expansion and onset of symptoms seems to reverse and potentially prevent that from worsening. Yet persistence of the CAR and persistent functionality of the CAR targeting BCMA doesn't seem to correlate with recurrence of symptoms. And so it begs the question, is this truly an on-target effect? Is this more of a broader inflammatory issue, or is it just that with the high ALC, the probability of a rare event, say targeting a very low level BCMA expression in the basal ganglia or elsewhere, it's just higher when you have 30,000 CAR T cells versus 500 CAR T cells per microliter of blood? And so is it a probability game? But I really don't think we have a good understanding of what's primarily driving it. But I will say that these kind of neurotropic symptoms, right? The cranial nerve palsies, the Parkinsonism, the Guillain-Barré syndrome, the personality changes. And that's what I'm really trying to kind of capture with the term NINTs, which I think is a better term than MNTs or these kind of other things where you have your ICANS neurotoxicities, but there really are these pretty profound and potentially irreversible, especially when you're talking first-line myeloma or second-line myeloma therapy in, say, a 45-year-old. To really understand what that is and try to use the same terminology to define them and potentially even grade them. And I know that ASTCT is working on another manuscript to try to better encapsulate this so we can all use the same language and hopefully quantify this in a better degree. But ultimately, it was the lack of understanding of a mechanism and association with the CAR T expansion. And so whether this was on or off target, it clearly is associated with some kind of inflammatory or immune response.
Wonderful. Thank you very much for the explanation. And we already have a lot of questions. One question, and maybe both of you can tackle this. Why do we see this more with the cilta-cel construct specifically, and not with ide-cel, but there are also other academic anti-BCMA CAR T cells, one from Spain, a few of them from China, and actually the only higher frequency is reported with cilta-cel. What is unique about this construct, which, by the way, in terms of efficacy, is quite amazing, because as I mentioned in my introduction, we have 1/3 of the patients who are living long and disease-free after 5 years, and they have received a median of 6 lines of prior therapies.
I'll start off with this one. So, the main differences of the different constructs, and I think this is unique to multiple myeloma, unlike lymphoma, where in lymphoma, it's all single chain based binders, and they all use FMC63, which is a kind of publicly available murine-derived monoclonal antibody. And so when you look at ide-cel, it uses a single chain variable fragment that's humanized. When you look at cilta-cel, it uses a bivalent, so it binds 2 epitopes for BCMA, and it's derived from a camelid or a llama derived heavy variable fragment. And then there's other products like anito-cel and other binders that use things like D-domains or other kind of novel constructs. And so the real fundamental difference here seems to be the binder, which I don't want to necessarily kind of completely put it on that, but there was another company that actually had a camelid-derived a monovalent binder that did actually report an episode of Parkinsonism in their phase 1 study. And again, that was a camelid-derived binder. So the easy answer is that. But I don't necessarily know if that's the full story. I think there are some other attributes of cilta-cel that are a little bit different. It tends to, in these patients that get these symptoms, they tend to have more prolonged expansion, but also persistence. And so in most of these patients who develop Parkinsonism, they actually have persistence of CAR T cells at a much higher degree than you'd anticipate, anywhere from, say, 30 to 60% of circulating T cells at, say, 30 or 90 days out. And so they tend to be expanding more, but also persisting longer than some of these other constructs, which could be related to manufacturing or overall vector design. But the easy answer, at least in my viewpoint, is the binder. But it's really hard to say because, as you mentioned, we are seeing it, in other, and I have seen at least a single case in ida-cel.
Yeah, I completely agree. We don't know, and somehow all this, Dr. Moti, this rare toxicity is kind of keep coming back to cilta-cel, right? Like the colitis, which has been described with the cilta-cel at higher frequency, and compared to ida-cel, I haven't seen one actually yet. So I think it's probably both the product construct factor as well as something to do with the recipient host immune system and how it allows prolonged rapid expansion and persistence of these CARs. But it's certainly fascinating that why all these rare immune-related side effects keep happening with the cilta-cel only.
Yeah. It is interesting too, is that the cases of T-cell lymphoma, which I think were big in the news maybe about a year or two ago, have really actually the only cases of T-cell lymphoma that have confirmed CAR integration into the T-cell clone have been cilta-cel. There have not been BMS, Novartis, Kite Gilead. No one has actually identified a T-cell clone other than an Australian group who are using the transposon system many years ago, published in Blood. But it is interesting that this profound expansion, prolonged persistence, and then generation of potential clonal selection for, say, a T-cell malignancy are primarily being driven by cilta-cel. So there seems to be something connecting all these things together.
So as we say, there's no free lunch. So efficacy sometimes comes with some risk. So both of you mentioned the issue of probable correlation with the expansion. Is this something well established, and should we monitor this very closely in order maybe to intervene preemptively or very early? What are your thoughts, your experience?
So,
Matthew or Baggy, yeah, sorry.
So again, we and other group has kind of seen this pattern where especially the ALC trend during the first 3 weeks after the cell infusion somehow predicts the higher toxicity, both the CRS and neurotoxicity. But I was going through actually the table from this manuscript, and it seems like it's kind of all over the place, and there is no clear pre-CAR infusion characteristics from the patient or disease-wise that will predict who's going to end up with this rare neurological event. So there's definitely been case by case of use of prophylactic dexamethasone. Especially we had a lady with on dialysis, older lady, and had a ALC of 25,000 2 weeks into the cilta-cel infusion, and we decided to pursue prophylactic dex in her case. But I think we definitely need more data before we kind of come up with some more generalized treatment algorithm.
No, I agree, and it's hard. Like in some instances, I've had patients where they've been very afraid of these toxicities. They kind of wanted the best of both worlds, and so actually gave them prophylactic steroids because they were just like, one of them was actually he manufactured viral vectors and was very, very astute in terms of the science behind a lot of these things. And he still developed bilateral cranial nerve palsies on prophylactic steroids. So I don't know what we're really treating here other than our own anxiety in many instances. And so I'm hesitant to say use such a big gun as cyclophosphamide because, as we point out in the paper and others have mentioned, high-dose cyclophosphamide is not easy to give. It can sometimes cause more protracted cytopenias in patients that already have pretty profound cytopenias and beat up bone marrows. And the things like CMV, BK virus reactivations are non-trivial, right? And so these patients are already suppressed and have multiple infectious complications without cyclophosphamide after BCMA therapy. And so, this is not a benign intervention at this point. We don't necessarily have something that seems to kind of be the magic bullet, but our approach has been to watch patients very closely to educate them and their families and their referring physicians when they go back, and especially in that first 3 months to say, if there is something happening, to please let us know immediately, because I think that earlier intervention is probably helpful, but I don't think prophylactic use of these types of agents necessarily is warranted at this point.
Wonderful. One question we have, and this is in line with what you wrote, Matthew, and your co-authors in the discussion. that there was a lack of uniform, complete clinical responses to cyclophosphamide, as well as delayed full symptom recovery. So the question in line with this we received is whether maybe additional doses are needed. Is it about a single dose, or maybe you needed to, you undertreated maybe some patients?
No, it's a good question. And we've thought of that. It's hard to give Cy/Flu, followed by 2 grams per meter squared of cyclophosphamide plus additional doses of cyclophosphamide in patients, especially when their ALC has really bottomed out. So, the key thing is, as long as I'm seeing the ALC go down to, say, like, 200-300 from whatever its peak is, I typically consider that sufficient enough. There was another group in Chicago. I think it was Dr. Caitlin Kelly had published a series where they were using intrathecal chemotherapy for patients who were having these very similar type symptoms, and this was in Blood Advances maybe a month or two ago. And so that would be another option that we would consider. But it also, we make an assumption here that this is all the same mechanism. I kind of keep going back to a lot of hand waving here, but patients who didn't have high ALCs can still develop Parkinsonism, and patients who have high ALCs don't develop Parkinsonism. And so I think we're using this as a surrogate right now for CAR T expansion, but again, it could just be a very rare event. And I think both, when these symptoms start to develop and then when we recognize them, the reversibility may depend on that timeline. And so although we may be able to reverse it in some, if we let this linger, and we had some patients that we reported on that, presented, and it was grandma was falling a lot. And it was because her gait was getting smaller and shorter and she was becoming weaker. And by the time we found her, she had stopped eating. And at that point was, we had tried cyclophosphamide, we had tried intrathecal therapy, we tried dasatinib, we tried Jakafi, we tried anakinra, we tried cetuximab, we tried everything, just trying to reverse this in this poor woman. And nothing worked. And the interesting thing is autoimmune panels, nerve biopsies, muscle biopsies, CSF sampling, everything was pretty benign. And so again, it just points to, I don't know what we're treating. I just emphasize that point, but I don't want to make it seem like everyone should get cyclophosphamide, but also emphasize that we really need to understand what this is, why this is happening, and we need to report it when it does, so that we can really get a better understanding of what's driving this, and we can come up with a better solution.
Thank you. One question for you, Baggy, is about, can we pre-identify those patients who have a high risk of developing this kind of neurotoxicities, and maybe in this kind of patient avoid using cilta-cel and use other approaches? Any thoughts on this? How do we do it in your routine clinical practice?
Yeah, so the answer is no, we don't really know, because this has been described across the disease burden, even the low disease burden myeloma, without extramedullary disease, without major organ dysfunction like AKI or liver issues. So we have seen this across the board, even in where you really don't expect to have too much of a toxicity, where patients do present it with this late neurological event. So the short answer is, as of now, we don't know really the reliable clinical factors. When you're actually counseling the patient, you have ide-cel and cilta-cel both available to you, and these are the risks. How are you going to choose between them? So in my practice, at least, and again, I'm just speaking for myself, because there is even variation in practice among our group, 6-7 transplant CAR T doctors, and each of us approaches differently. But in my mind, these patients, especially if they are coming in early relapse multiple myeloma, they have not seen bispecifics before, and they are 70 plus. I'm leaning more towards ide-cel just because of its proven safety. I can get 1.5 to 2 years of PFS, and I can then use the talquetamab or other bispecific, get them up to 75, 80 years of age. They have lived their normal life expectancy at this point. So, and I have an honest discussion with the patients about this risk-benefit calculation, which I do in my head, and let the patient decide if they want to, the longest disease-free survival, potential cure in 1/3 of the time, but the risk of having this rare event and may end up with a long-term deficit from this, versus going to ide-cel, which we have used it longer and we know. On the vice versa, I have a younger guy, multiple refractory disease, extramedullary disease. I always prefer cilta-cel in that situation, and despite this potential risk. So it's
Clinical
definitely
judgment always prevail. Matthew, any recipe from your experience?
No, I completely agree. I think it's hard to really quantify something and kind of tell you what your clinical intuition tells you. But older patients, at least from a fundamental level, if these symptoms do recur, they tend to not bounce back as easily, right? So if they do develop weakness, gait issues, malnutrition, they don't really recover well. They don't rehab as well. And so if you've got a 70 or 80-year-old, if they get subtle symptoms, it may be more detrimental for them. They also don't tolerate high dose Cytoxan and the interventions we've used as easily. And so they're more likely to have complications from that. Otherwise, we do actually use a good amount of ide-cel still. And we have an ongoing study right now using elra maintenance following ide-cel, hoping to really drive patients' MRD down. And hopefully that will translate to PFS. But I will say one of the things you can do if you're going for ide-cel is really debulk patients, right? Try to get the disease burden lower, try to get patients into the best possible situation, because the patients who are MRD negative at 1 and 12 months who get ide-cel had a PFS of around, I think it was 34 months when they looked at the retrospective data. And then lastly, we do have ongoing studies with things like anito-cel. Currently, we just finished recruiting the phase 2, and then we have the phase 3 for second line to fourth line. And that's treated now about 300 to 400 patients that I'm aware of. We haven't actually had a case of colitis or Parkinsonism. So again, BCMA targeting, different binder, unclear what's happening, but that PFS was upwards of around 30 months in the phase 1 study of around 38 patients.
Excellent. So, and you mentioned very nicely, Matthew, and I was aware of it because Dr. Nupur Raji presented this. You have this beautiful study, which I like a lot, with ide-cel followed by consolidation maintenance with elranatamab, a BCMA T-cell engager bispecific antibody that works very beautifully. And one question we received is there an explanation while the target is the same and we usually treat until progression and rather high doses probably, that we don't see any major neurotoxicity with bispecific antibodies versus the CAR T cells? While, of course, patients love CAR T cells because they have this so-called treatment-free interval.
Yeah.
Thoughts?
Yeah, I think it comes down to like bispecifics are fantastic. I think they brought in access to highly effective therapies to patients who may not have access to CAR T cells, and they're actually great for, in my view, for salvage following CAR T cell relapse. And so I think it's not, from my view, it's this or that. It's at what point in time will we eventually be using these together, and what is the appropriate sequencing of these therapies? So I think we'll have a world there where they'll be used together, but when you look at the PFS of bispecifics versus CAR T cells, you look at the MRD negativity rates and the CR rates, the rates of toxicity typically correlate with the degrees of response. And so when you have more highly effective therapies, you're more likely to have some of these toxicities. But again, I think there could be something unique with camelid binders or cilta-cel that it's really driving this conversation, because if this was 1 out of 1,000 events, I don't think we'd be worried about it as much. It's looking closer to, say, around 5%. In some case series. And so I think that's why this is a more important discussion, especially in second line therapies.
Wonderful. One question for you, Baggy, we've just received is, well, actually, the colleague is mentioning that the cevostamab protocol, which is a bispecific targeting FcRH5, used for all patients tocilizumab prophylaxis. So everybody would receive tocilizumab. And the question is this something, this approach, something you would do when using CAR T cells?
Yeah, no, not in outside the clinical trial, really. We did prophylactic toci as a part of one of the ZUMA-1 cohort back in the days in diffuse large B-cell lymphoma with CD19 CAR T, Yescarta. And a few things emerged. You can safely do prophylactic tocilizumab and reduce the higher CRS events. But the second signal emerged was there was actually no change in impact on ICANS. In fact, there were a few higher incidence of ICANS events in that small 40-something patient cohort. So in our practice, at least, we've not been doing the prophylactic tocilizumab even in CD19 CAR T. We do prophylactic dexamethasone for diffuse large B-cell lymphoma going for axi-cell with high burden disease based on ZUMA-1 cohort 6 data, but we are not doing the tocilizumab yet. We did tinker with the idea of using it in our bispecific clinic, though, based on the recent publications on both teclistamab and talquetamab and prophylactic tocilizumab. But we feel that even in those situations, most of the patients do just fine with the dexamethasone. So we haven't used it in a broader sense. And I don't anticipate that toci prophylactic will have impact on ICANS because it's just a totally different mechanism of action.
Excellent, thank you. So Matthew, last week, actually, we had a very beautiful webinar about outpatient CAR T cells. So I don't know whether you are doing outpatient CAR T cells, but let me ask the question in a broader way, where what kind of practical recommendations, guidance you would give to colleagues who have less experience, because obviously now with the long-term follow-up, my best guess is that cilta-cel will spread everywhere and people will be very keen to using it. So what kind of recommendation guidelines you would give to people on how to monitor these patients, both clinically, biologically?
Yeah, no, it's a good question and something we're working with now. We're doing around 20 to 30%, I believe, of our CAR Ts outpatient. We're somewhat constrained by high cost of living and hoteling in the Boston area. And realistically, if a patient calls 911, they get brought to the nearest emergency room, and that could be one of 5 hospitals in the Boston area, between where we are now and where they're living. So, a lot of it comes down to patient selection, right? That includes both biological features, baseline inflammatory disease burden, things like that, as well as social support, transportation, access, means in terms of families being able to get them back and forth and cooperate. So I think there's that initial evaluation we do with social work to really kind of understand what are the biological components at screening, but what are the supports the patient needs to succeed at that. And so we really think about that there. And then they really have a backup plan. And so we usually have at least kind of one infusion chair open 24/7 so a patient can bypass the emergency room. Everyone goes home with high-dose dexamethasone so they can take some orally if they get into trouble. And that's worked well for us. And I think cilta-cel is one of those products that really lends itself to doing outpatient CAR T. In my view, we do a lot of ide-cel, but we don't do a lot of ide-cel outpatient just because the median onset is so soon following infusion. If you're going to admit a patient that quickly, I don't know if it really makes sense to kind of roll the dice and just try to keep them out for an extra day or two. But there's also no sense in having a patient in the hospital for a week waiting for CRS to occur just to watch them for another week with something like cilta-cel. So I think with cilta-cel, it makes a lot of sense. And one strategy we did that I'd highly recommend for new centers is we actually planned a day 4 admit. And so while we were getting off the ground with outpatient infusions and our monitoring system, we would just plan to admit the patients on day 4 or 5. And so until we really got a feel for how patients were doing, we were really capturing the patients as they were fevering once they're in the hospital. And then we, made the staff really confident and comfortable to continue to proceed forward.
What is the experience in Nashville, Baggy?
Well, the housing costs are not as high as Boston, but we're getting there, hopefully. So we are 100% outpatient allo CAR auto program. Our default, regardless of the patient's biology or the disease burden, is to do outpatient. Every patient, really. I can think of a handful of cases where we preemptively admitted them. And the reason, and they were like leukemia patients with quite sick patient, active disease. So, but in myeloma, we are actually able to do all our cell infusion and only admit them for grade 2 or higher CRS or any ICANS, we admit them for the monitoring. And I would say around 2/3 of the patients are able to stay outpatient because we have capacity to give outpatient tocilizumab in our infusion center, which is open 7 days a week. And after hours, we have on-body sensors and a CAR T nurse practitioner who monitors this patient remotely. And if they have fever or any significant change in the vitals, then we call the patients, we do the remote video call visit at nighttime with the caregiver to do all the ICE scoring and CRS evaluation. And if they are stable enough, we keep them in an outpatient setting. Otherwise, we admit them.
Excellent. So one last question now to you, Matthew. After this beautiful paper, and I think this is going to be extremely useful to the community, because despite the uncertainties, you are providing an important tool to try to help these patients struggling with these non-ICANS, or you prefer to call it NINT, correct?
Yeah.
Let's see whether this new acronym will make it.
We like our acronyms.
Okay, so what's the next step in terms of research? What's your roadmap in this field?
Really good question. We have a rather large cohort of patients with multiple BCMA products, anito-cel, ide-cel, cilta-cel, some of our own homegrown. And so we're trying to do a deeper dive in patients with and without various toxicities, including colitis, both on the single cell as well as the baseline immunophenotyping, to understand like what predisposing factors or what signatures are we finding within patients who are developing toxicity, to see if there's a common thread that we can pull. So there's kind of that side. It's just casting a wide net and trying to really, drive into the commonalities in this patient population, both at the kind of clinical level, so you can make real-time decisions, and also at the translational level. So all that work is ongoing by many of the same people around the manuscript you described that's here. And then we also have other studies that are ongoing. So we recently published our anakinra cohort for at least large cell lymphoma, which is another agent that is commonly used for these toxicities, especially ICANS, as well as a study looking at emapalumab, so blocking interferon gamma, which seems to be a driver for CRS and ICANS in post-breakthrough TOSI and Dex and anakinra, and has shown at least some activity without interfering with efficacy in BALL. So I think, and there's also a paper coming out, should be with a JAK1 inhibitor with itacitinib that we had looked at, which actually did show a statistically significant reduction in the rates of grade 2 or higher CRS in a blinded placebo-controlled fashion. So I think there are a lot of really interesting strategies out there that a lot of groups are looking at. And the nice thing is, with these targeted therapies, we can really tease apart inside the patient, what are the mechanisms of toxicity, what are the pathways that are driving it, by blocking various nodes and understanding how do we perturbate the system, and then how do we improve and or make things worse. And so, we're still learning a lot. I think it's really exciting. There's a lot of opportunity for a lot of people to, to really get into this and understand what's happening.
Thank you very much, Matthew. Thank you, Baggy. I believe, thank you both for sharing your insights, your experience. Again, congratulations for this blood manuscript, which has just been accepted using high-dose cyclophosphamide to manage non-ICANS neurotoxicities after cilta-cel in relapse refractory multiple myeloma. I believe the management of neurotoxicity following CAR T-cell therapy in general remains a critical challenge in our clinical practice. And as it has been highlighted in today's discussion, early recognition, standardized grading, prompt intervention are clearly essential to improving outcomes. Hopefully, we'll see in the near future advancement in biomarkers, maybe imaging. We didn't discuss the role of imaging there because of time, and maybe identifying or risk stratification for more personalized approaches. But one thing for sure is that sharing experiences like today, continued collaboration will be key to refining our strategies and ensuring both the safety and efficacy of these transformative therapies. So thanks to our panelists. Thank you all for your active participation, for your questions. I do apologize if we were not able to handle all questions, because you had a lot of questions, but I'm sure you can reach to the panelists by email or any other tool, and they will be more than happy to answer your questions. And here at the ICH, we look forward to welcoming you to our next webinar, but also our next ICH Donor Club session early July. Thank you very much. Wherever you are, please stay safe and keep well.
Thank you.
It's